Our next speaker is Juliette Mewton, and Juliette's a fellow at the Royal Brisbane and Women's Hospital. She's doing an interesting program. She's implementing a relatively new concept of senior clinician and senior nurse providing after-hour leadership and support for patients on the ward. She's going to talk to us about the role of the parent team in end-of-life care today. So welcome, Juliette.
Hi, thank you for giving me the opportunity to present today. So this is a pretty hard audience to talk to, I think, because everyone in the room would agree that the ideal scenario is that the home team has this discussion with the family. So the burden of end-of-life care is quite significant. 20.4 million, it's identified, need end-of-life care. Our population becomes increasingly elderly, increasingly complex. And I think there's an increasing reluctance and lack of familiarity with the dying process. Very few people die at home anymore. And it's not uncommon, sadly, to have a conversation with a relative who says, you know, what do you mean my 95-year-old mother who's got dementia is dying, what can you do to save her? And I think that's one of the challenges we're going to face as intensivists moving forward, is the people that we say no to in terms of ICU admissions. So the World Health Organization rightly says that palliative care should be effectively delivered at all levels of healthcare, and I strongly advocate that in hospitals we should be able to give people good deaths just as much as we give them good treatments. Sadly, it's becoming increasingly challenging for patients to get transferred into palliative care wards. There's just not enough beds and spaces. And up to 50 to 75% of patients with chronic disease status is now dying in acute care settings. So death can be anticipated. And in that scenario, we would all advocate that discussion should be held with the home team in a planned setting. But sometimes death is unanticipated and unexpected. And as intensivists, we're increasingly called as the emergency response. So I think we all think we're quite good at discussing both treating patients and treating dying patients. And I notice now there's a wealth of books out there where different specialists have shared their experiences of managing patients. And as you can see, a lot of them refer to life and death. But I think we'd all agree that home team care could still improve and home team engagement could still improve. So I'd just like to present to you some stats from our hospital. So 14.5% of patients who have a medical emergency response have an ARP, an Advanced Healthcare Directive, or a completed statement of choices that's found on subsequent review of the paperwork. Now, on top of that, over 72% of doctors at a medical emergency response found it difficult to actually find the paperwork. So we have combined medical records online and also clinician notes. And it's not uncommon that the documentation of an ARP is not clearly found. Even our consultants, so we surveyed 75 consultants from 13 different specialties, and 74% of them acknowledged that half the time or more, their patients had inadequate advanced healthcare planning at the time of deterioration. So they're actually aware that it's not happening as well as they'd like it to, but there's lots of problems in the system that mean that it's very difficult to fix and it's very difficult to rectify. It is, as has been discussed in the last talk, a common precipitant of conflict. Now that can be conflict about disposition, it can be conflict about diagnosis, and it can result in triangulation of conflict through treating registrars at the bed space, communicating with remote consultants in different specialties. So it's really important that we're all on the same page in terms of delivery of care.
83-year-old
This is
Dorothy
just an
was
example.
admitted 2 weeks ago with a gangrenous foot. a potentially life-threatening condition.
So we've got a slightly difficult problem, haven't we? This
In terms of our aims.
well, this is not going to heal. This is not going to heal us. Okay, I think that if we amputate her leg, that actually it's not going to prolong her life.
No.
Mrs. Barnett, what we're saying is whether you want an operation for us to do an amputation of your leg.
Does it have to go that way?
No, it doesn't have to go that way. It doesn't have to go that way.
So I think one of the problems is we see all the examples of where we think things could have been done better. But I actually think that a lot of our colleagues do really good work. And a lot of these decisions are made in the appropriate setting through general practice and through our outpatient clinics. So we have very limited access to palliative care in our hospital, but they are now beginning to penetrate some of our chronic diseases clinics. So it means that patients can actually have those end-of-life care discussions outside of the acute hospital setting, and I think that's a really positive step in the right direction. One of the areas where people always say we should discuss more is emergency. I actually originally trained as a surgeon, and I now dual work as an SMO in emergency and in intensive care, so I guess I see everything. And I think that we underutilise having those discussions in emergency, either by the home team or by the emergency department. So it's the perfect time when everybody's anxious, where there's been an acute crisis, to have this discussion, and the discussion can be normalised. So you can easily say to families, we try and do this for every patient who comes through emergency, and we'd like to have an open discussion with you about end-of-life care. And it's actually usually a very effective place and an easy time to have that conversation. Where I think it gets really complicated is when we have a patient who's been in intensive care, that's discharged back to the home team on the ward, and then 3 weeks later, when they fail to thrive, there's a suggestion from a MERT call that there's an end-of-life care discussion, by which point the family have got used to being institutionalised, they've got used to visiting their relatives, they're visiting less, they're less engaged, and they think that their relative's getting better because they've been discharged. So I think none of us want to end up in a situation where we're having this difficult conversation with a substitute decision maker because the patient's no longer in a situation where they're able to participate or decision make. There's also some really good studies out there looking at the use of a substitute decision maker in making decisions about advanced resuscitation planning. And all those papers indicate that there's a high level of stress associated with the decision making, that it contributes to conflict between family relatives because it's not uncommon for them to disagree in their opinions or understanding of a case and whether they want escalation of care. And there's also good evidence that the substitute decision maker cannot isolate their own wishes and views from reflecting the wishes and views of the patients. I thought it was quite interesting. I was trying to look for some evidence about home team end-of-life care discussions, and it's when you actually Google home team, as I did, end-of-life care by the treating team, it actually produces a whole page of references just to palliative care. And I think that's one of the problems, is that sometimes the home team do struggle to see that it is their responsibility to have that decision, or can be uncomfortable to have that decision. I was having a chat with one of the physicians in my hospital the other day about instituting end-of-life care discussions on the post-take ward round for the physicians. And I think we forget that the home team come from a very different perspective. So the first thing he said was, well, I'd obviously never have that discussion when I haven't, got to know a patient, understood the complexities of the case. I would always defer that decision making. Whereas for us, we often don't have that luxury. We're called in an emergency and forced to have the conversation whether we like it or not. I think where the home team haven't had the discussion, as I've said, it can fall down to us. And I think, having chatted to quite a few intensivists recently, the burden of breaking bad news weighs fairly heavily. And increasingly, people are feeling that they are doing it more and more. And I think it's also difficult. We have a mandatory attendance, attempted mandatory attendance to our medical emergency responses. And one of the problems for our surgical patients is that often a resident is sent and all the rest of the team are busy in theatre. So one of the strategies that I try to promote in my education is how the medical team leaders and intensive care registrars can actually have a meaningful discussion with someone of enough seniority to resolve the issue. So, for example, using the anaesthetist in theatre as your point of escalation rather than theatre reception or a scrub nurse, where often the message doesn't get through effectively and the right people are actually not that busy around the bed space and can come and participate in the decision-making and care. One of the other challenges we had, the surgeon's getting a bit of a hard rap in this talk, but it applies to a number of our subspecialties, is where we identify that the patient needs an ARP, but there can be quite a bit of resistance to actually getting that ARP in the notes. I think we just have to remember that sometimes what's clear to us is not as clear-cut in the home team's mind. So, for example, chemotherapy, the treatment options from chemotherapy change continuously. And what we may have perceived as a once terminal diagnosis now can have a fairly good outcome. So just being mindful that it is their patient, and I think we really need to listen to our colleagues as to what their views are and why they feel that active treatment is appropriate. So I think we've sort of hopefully highlighted a lot of these as we've gone through the talk. Through the talk. But we do find it hard to offer comfort care sometimes in preference to curative treatment. And obviously curative treatment is appropriate for a lot of our patients, but sometimes delays in identifying the dying patient results in discomfort and distress. The hospital systems are challenging. So as I showed in a slide earlier, our MERT team changes in its attendees multiple times throughout 24 hours. And that leads to complexities in discussing these end-of-life issues if the home team aren't involved and if we don't continue to involve the whole home team when we go to medical emergency responses. Sometimes a bad discussion can be worse than no discussion. And I'm sure we've all been present where we've seen patients have end-of-life care options discussed in a suboptimal way. I think we still, certainly in my area of Australia, we really underutilise the multidisciplinary approach to complex care. But patients should not be offered the shopping list of treatments. And when we do a form, we need to include all forms of organ support because it's not uncommon to be called to say, you know, the patient's not for intubation, ventilation, but can they have dialysis, please? And I think if the conversation was held properly the first time, that would be a big step forward. Documentation. If you have the conversation, the home teams need to document who they had it with, what was said, because otherwise, when we get called, it might not be as straightforward as it seems, and actions might be taken that the home team don't agree with. And I think the other thing is sometimes, you know, these multidisciplinary conversations are really important because some of the home teams can get quite focused on the specific disease process that they're managing, and it doesn't always get put into the relative comorbidities and other existing problems that the patient has.
Yes, hello. So how much have they told you about what's going on and things?
I went to see him this afternoon. We thought he got a cold and a bad throat.
At the moment, his oxygen levels are very low.
Okay.
And he had some bits in his throat, like tablets and things, that were in his airway.
Right.
So we think they've gone down the wrong way, essentially, and they've gone onto his chest rather than going down into his stomach. which might be causing him to have an infection in his chest and making his breathing quite difficult.
Okay.
With him being in the home and things, he's got a note to say that he didn't want to be resuscitated. Is that right?
Yes.
Okay. So there are more treatments that we could give, but at the moment, with him being in the state he's in, I'm not sure that they'd be appropriate.
No, okay.
But I just wanted to make sure you understood
Yeah.
where we were.
Yeah. All
And
right.
do you want a cup of tea or anything?
Mind a
Cup of coffee, yeah? Oh, that was awful. Daniel, you idiot. Dear me. Basically, I did it all wrong. I should have... I'm not sure the bedside was the most appropriate place when we've got a very good relatives room. I don't know, it didn't feel fluid and fluent, and I didn't feel happy that I'd got across what I was trying to get across in a sensitive and compassionate way. It felt a bit like I was kind of panicking. And I think there was an element of that, because as I was getting through it and I was thinking, I'm just talking now, I need to stop talking. And, yeah.
So, I think, sorry, with the way it's set up, I haven't been able to introduce the slides before I start them, but whilst we want the home team to take responsibility and we want them to discuss end-of-life care, as was highlighted in the last talk, the genies don't get much training. They're not very experienced. And it is a significant stressor, and it can be done badly if it's done by the wrong person at the wrong time. And sometimes, I think as intensivists, our support and input early can make a big difference. Generally, families often express dissatisfaction about end-of-life care in hospitals. And early discussions prevent delayed decisions and delayed discharges so patients can die at home. The other thing is that we often don't pick up on the patient's cues. So there's a lot of low-lying fruit out there. And one of the things we do is we have a post-MERT ward round. So every morning we go around and see all the patients who've MERTed in the last 24 hours. And we discuss those patients where end-of-life care planning, involvement of palliative care could make a difference. And that's made quite a significant impact on patients and their families. So, in summary, failure to address end-of-life care from the home team at a cardiac arrest particularly can cause significant distress. It also increases the risk of you resuscitating a patient inappropriately, and it also alters the family's expectations. So, one of the things I still question that we do in intensive care increasingly is keep patients alive whilst relatives come to visit them. And one of my physician colleagues flagged to me that, it was something as a concept they struggled with because they didn't have the opportunity to do it for their patients. And I think it's something that we really need to consider in our practice, that we're really doing the right thing by our patients and our relatives. As was discussed before, burnout is an issue, and intensive care has a very high rate of burnout. And out of hours and emergent discussions should be kept to a minimum. So in summary, the home team really do need to be involved. They do need to set the expectations for the family. Early decision making prevents conflict at the bed space. It reduces stress for staff, and it improves satisfaction of relatives who are left behind. And I think everyone in hospital should have a good death.